Hello, my name is John Kelly, one of the medical educators at NTGPE. This short 20-minute YouTube clip is really just to give you a brief summary of what we went through in Supervisor Workshop 1 as regards tapping into the best available evidence. And the purpose of it is to be a foundation for this current workshop. Hope you find it useful. The first point we made in that workshop was that knowing how to empower your GP trainees and how to use the best available evidence is only a small part of what we do as doctors, and that a large part of what we do is tapping into our individual clinical expertise and finding what a patient's values and expectations are. However, I did make the point that it is still worthwhile knowing how to tap into the best available evidence and how to utilize this properly. And I decided to be the devil's advocate and give you 2 points of view of why you might want to learn this. For those that do appreciate that there's a value in evidence-based medicine, the point was that this will help you find some truths out there that you didn't attain through your clinical expertise or patient values and expectations. And that all along, we always do find the odd article that does change our practice. And for that reason, it's a worthwhile thing to do. But I also wanted to appeal to you, to the skeptics out there, that another reason you might want to learn how to apply best available evidence is to show when it shouldn't be used on your patient. And as if you may recall in the workshop, I was showing how by having a structured approach to looking at a paper, you can actually work out why a paper that is touted as, presenting a standard of how we should manage a patient sometimes shouldn't be applied to your patient. We then went through how to empower your GP trainee on how to use the best available evidence. And we started off with, well, how do you start with a question about a patient and transfer it into something you can search on a computer, on a database, to find the paper that's going to answer your question. So how to find the best available evidence. And what we're saying there is that there's 2 things that a GP trainee needs to do. The first is to work out what type of question they're actually asking, because this is going to tell you what study designs are actually going to answer your question, which is going to help you search. And the second is to break down your question to what we often call a PICO, or variation of. We then gave examples of how this applies in reality. So we started off with question types related to why that behaviour, attitudes or beliefs. So what are my barriers to my patients taking L-bicillin? And we came up with that you really want to search for qualitative research to get these answers, such as a focus group. That if our question starts off with us describing what we see quantitatively, so how often, how much, how long, for example, prevalence of methicillin resistance amongst our Staph aureus isolates in oils, that we're really after a quantitative descriptive study. So, for example, an audit or survey. And if our question is a bit more complex, where you're comparing 2 things, such as treatment versus no treatment, an etiology versus no exposure to the etiology, whether an ISTAT machine, how that compares with a full blood count, or prognostic question such as how long will my patient with Alzheimer's, early Alzheimer's disease live for, compared to someone who's similar who doesn't have Alzheimer's. Then you can look at what are actually more complex sort of studies. And we did show this graph here, where we went at a little bit more detail, pointing out that for a therapy question, the top of the pile is a randomized control study, followed by these other options here. Just get my little pointer, non-randomized control studies, or cohort studies and case control studies, followed by case series. And you can see that it's a different order for diagnostic questions and a different order again for harm questions and prognostic questions. And I did make the point that this is how we actually arrive at our levels of evidence. So you work out what your question type is, work out what your study is, and then work out what level of evidence that fits in with. I did make the point that, strictly speaking, a systematic review of the level 2 studies trumps a single randomized control study. There's a little bit of debate on whether that's truly true, but by tradition we put that above there. And the rationale is that if you've got studies that have negative results and some with positive results, that putting them all together might give you a better picture. And there's arguments to and fro, but anyway, traditionally we call that the level 1 evidence. And I did make the point, whilst we're on this particular graph, that we shouldn't be threatened by this graph. Some people think, wow, my clinical expertise doesn't rank very highly in this. But the issue is that that's a different part of the triad. That's our clinical expertise, and that has a different hierarchy in a sense. This hierarchy only applies when we're actually looking at best available evidence, which is a particular type of literature. And so it's just that we don't be threatened by this. We then went into the PICO more specifically, which having worked out the question type or variation on PICO. And we talked about what that actually is. So PICO being population intervention comparator outcome. So, you know, had a bunch of women with first trimester vomiting and had one ask me, or could I give Phenergan, how would Phenergan compare with Maxilon in terms of treating vomiting? I could maybe do a search on women with first trimester vomiting. The intervention could be Phenergan, the comparator could be Maxilon. Not that I use Maxilon as my first line for hyperemesis, but just an example. And the outcome could be vomiting. But I also pointed out that PICO really, by the mnemonic, only represents this group of where you're looking at a treatment question, and that we have to vary the PICO for these other types of question types. So if it's a diagnostic question, the I actually becomes a test you're interested in, and the gold standard is the C, and the outcome is sensitivity and specificity. So HEMA-Q versus full blood count, in an indigenous population of children with anemia. My P is indigenous population of children with anemia. The I becomes the HEMA-Q, the C becomes the full blood count, and the O becomes sensitivity and specificity. For an etiology question, do brain cancers caused by mobile phone use in the Australian population? My P is the Australian population. The I is in effect we often call it an E for exposure, is the mobile phone use. The comparator is no mobile phone use, and the outcome is the incidence of brain cancer. And I'll just point out also that with our descriptive studies, where you, for example, prevalence of MRSA amongst our Staph aureus isolates of boils in my local indigenous community in Alice Springs, your population would become the local indigenous population with Staph aureus in their boils. There is no I or C because you're not actually asking a question that involves and you're not comparing things, and really just your O becomes the percent prevalence of MRSA sensitivity, of our methicillin sensitivity. We talked about how do you, having worked out your question type and your PICO or variation of what do you do next, and the next thing you need to do is you've got to look up the database. And we talked about how there's two types of literature out there. There's the primary research, which is original human articles, and then there's articles that synthesize these original research into various ways to give you a bit more of a digested summation of the evidence out there, and that there are these various forms, systematic reviews and evidence-based guidelines and so forth. And I just made the point that it's worthwhile looking up both sources of research when you're trying to search a database for a question. And the main reasons are that a lot of the primary research might be more recent than that systematic review that came out 3 years ago. And the other thing is that it actually gets a little bit harder to apply to a real patient, these pre-appraised research, compared to the primary research. So I guess the point I wanted to make there is it's worth looking up both. And then I made the point that there's various sources people look when they're looking up the best available evidence, and that the problem with a lot of them is they only search a small part of what we just saw then. So PubMed only looks up the original primary research, Cochrane and systematic reviews. Cochrane looks up systematic reviews only. UpToDate and Dynamed are evidence-based textbooks. Google looks up all forms to an extent, but isn't very systematic with what hits it gives you. And a take-home point I made was that Trip Database is quite a nice one for finding most of the pre-appraised and the primary research, with one of its weaknesses being that it doesn't cover all the evidence-based textbooks. I did make the point that I thought it wasn't too bad on Dynamed, although I must say last time I tried it, I had some difficulty, so maybe I'm not sure if that's entirely true anymore or not. And then we went through part of the last time's supervisor workshop on taking you through how to actually do a search on Trip Database, and I was just making the points that you put in your PICO, probably not too much detail, because if you have too much detail you won't get enough hits, and that you look at the hits they give you and compare it with the study design that you're looking for and the PICO that you had in mind of your patient, and then based on that you come up with the articles that you need. We then flicked tables and looked at how do you read a paper, and this is the bit that probably lends itself most to this current supervisor workshop. The system I recommended was essentially that you look at the question type, the study design, the PICO, ask yourself, do I trust the results, which is the internal validity, the trusting within what are the results, and then how can I have these results look after my patients, which is external validity. We started off talking about question type, so when you look at a paper you should just confirm that yes, it is a therapy question, and that yes, you did have a therapy question in mind. Look at the study design, and I gave you a nice little flow chart so you can work out quite easily in an article what type of study design it is. And then I asked you then to look at the PICO of the paper. And for a therapy study, what I suggested was that for the P, you look at the inclusion-exclusion criteria in the study setting, and that you then, for the P, actually go into the baseline characteristics, which is typically a table 1, sometimes an overflow into a table 2, which gives you a feel for who the patients were that really entered this study. So here's an example of a probiotic study, and we know that the typical population was late 40s, mostly female, mostly non-lactose or regular diets, previous probiotic users, some moderate exercise levels, not particularly heavy drinkers, and minimal smokers and so forth. So the idea is you're getting a real feel for how can I apply this to a patient. We then talked about the I, C and O of looking at a therapy study, and the point I made for the I and the C, the intervention, the comparator, is you look at what treatment the patient claims they were enrolling people to receive, but then look at the results and see what they received in reality. And they'll often have a pill count, or in the case of warfarin, it'll be how therapeutic the people in the intervention group were. And so you really get a feel for what the real I and the C were in the study. And then we talked about the outcome, the O, how the key thing there is to work out what's a primary outcome and what's a secondary outcome. And that as a general rule, there should only be one primary outcome. There can be more, but they have to jump a few hoops statistically to have more than one primary outcome. And that if you're really struggling to find out what the primary outcome is, because sometimes papers aren't that clear, you go to the statistics section, see what the study was powering, what hypothesis it was powered to actually answer, because that's the primary outcome. So that's these first 3 questions answered here. I then went through the next section, which is, do I trust the results? I made the point at this point that there are 4 possible explanations of any result: truth, chance, bias, unequal distribution of prognostic variables, and that when you have a result, it can be one of these four possibilities. And we talked about bias as being something that distorts the truth. It's a systematic error in a study, like the wind that knocks an arrow off course to hitting its target. And that the biases are going to depend on what study design you have. So for a randomized control study, where the power of it really relies on it being randomized, it's going to be, the questions you're looking at are things like, well, how well randomized was it? Were people aware of who was allocated to what? Completion of follow-up, how subjective the outcomes were, how blinded was the patient and the clinician to what treatment they received. And so you're going to have this, and I was saying how if you're trying to find out what are the specific questions for your type of study, that there are often these checklists, and we gave an example of a checklist that you could use for an RCT that had those sort of questions in it. And I was saying that the other part of it, of internal validity, is that you're looking at the table, the baseline characteristics, just to see how equally distributed the prognostic variables were. So if I had a study on hormone replacement versus no hormone replacement for cardiovascular events as the outcome, I would be making sure that their cardiac risk factors with the baseline characteristics are fairly well distributed. If one group had twice, if the hormone replacement people had less diabetes, less smokers, less hypertensive patients, I would know that I wouldn't be able to trust that result without somehow taking into consideration this unequal distribution of prognostic variables. So anyway, they're the two things that we look at in internal validity. And then we talked about results. We then went through a systematic way of looking at results, and I was a bit mindful here of not info overloading people, because this is the area that we usually lose people. But essentially the system, when you look at a result, certainly for therapy studies and harm studies, is you look at, is the result a primary or secondary outcome? And then how is the result actually expressed? And by expressed, what I mean is it expressed as a ratio, like a hazards ratio, odds ratio, relative risk ratio, relative risk? Because that tells me, for one thing, that tells me that the results, that a result that's positive, has to not include the number one in it, or was it expressed as a difference? So we went from 5 in 100 vents to 10 in 100 vents. So there was an absolute risk difference of 5 in 100 vents, and the reason that's significant is because that result, a positive result is when it's more than 0. So it's as opposed to 1. So that's one of the main reasons that's relevant. We then looked at the result and turned it into a 95th% confidence interval, which basically means if I did that study 100 times over, 95 out of 100 times, what would the true value of the result lie? What range would it lie between? Having done that, we then decide whether the result is positive or negative. So, and if it is a positive result, then we go to the p-value to make sure it's to see how much role chance would have played in that result. Whereas if it's a negative study, i.e. there was no difference between the treatments or the exposure and the non-exposure, then I look at the sample size calculation and make sure that there wasn't enough patients in this study to be more than 80% powered to detect an absence of difference between the treatment and the non-treatment, or the exposure and the non-exposure. And then having done that, we try and make the result more meaningful. And by more meaningful, what I mean is if you've got a ratio, let's say I found that taking Fluclox doubles my risk of hepatotoxicity compared to dicloxacillin, and that's true. Well, you want to work out, well, in absolute terms, what does that mean? So and that means, so what's the absolute risk difference? And let's say in that population it went from 2 in 100,000 to 4 in 100,000. Well, I know that I'm actually only increasing my risk by 2 in 100,000, and 100,000 divided by 2 is 50,000. So I'd need to treat 50,000 people to harm one patient, as opposed to if the incidence was 10%. So the point is, bottom line is primary or secondary outcome. How's the result expressed? Is it a difference or a ratio? confidence interval, then look at that confidence interval, ask it's a positive or negative study, and then for those with positive results, try to make it more meaningful, which often in therapy studies and harm studies talk is about number needed to treat, number needed to harm. And I'd like to briefly take you through how I explain this concept to the trainees. And what I do is basically get them to imagine two patients, Peter and Rachel, and then you're looking up their lipids. And I point out that when you look at their lipids, you notice that Peter's LDL is 4 and Rachel's is 2, and otherwise the lipids are very similar. And I tell them that what we know about statins is that for every 1 millimole reduction in LDL you get, there appears to be this 25% reduction in cardiovascular events. In other words, there's a relative risk reduction of 0.25. That's what 25% reduction is. And I say to them, if we were to give Peter and Rachel a statin each, the same one, and they both got the same 1 millimole reduction in LDL cholesterol, who would benefit the most? And they think about it for a while, and often they say Peter, and other people just shrug their shoulders. And then I introduce a new concept, and I say, what if I was to tell you that Peter is a teetotaler young man without any cardiovascular risks, and that your estimate is baseline risk of a heart attack in the next 5 years as being 8 in 10,000? And then I say, and what if you thought that Rachel's got diabetes, chronic kidney disease, and smokes, and you've estimated their risk of a heart attack in the next 5 years as being 8 in 100? And then they often come back and say, well, actually, I think Rachel's probably going to benefit the most. And then I introduce a new concept. I say, in absolute terms, by how much are you actually reducing Rachel's risk of a heart attack in the next 5 years? And the same question for Peter. And what I really do is take them through the maths here. I basically point out that to work out this, you get your relative risk reduction, which is 0.25, times it by the baseline risk, and that will come out with the absolute risk reduction. So in absolute terms, this person is going to go down by 2 in 10,000. So they started at 8 in 10,000 and they're going down to 2, which means they're going to end up with 6 in 10,000 chance of having a heart attack thanks to being on the statin. So that's how I introduce that sort of concept. I do the same thing with Rachel. And then I say, have you ever heard of the term number needed to treat? And they may not have. And I say another way of expressing it is, how many Peters would you have to treat in the next, for 5 years of statin to stop one heart attack? And I then get them to go through the maths of that. Sorry, coughing. And basically I take them through the concept that you just go 1 over that absolute risk reduction, which will give you 5,000 over 5 years for Peter. So you have to treat 5,000 Peters to stop one heart attack in the next 5 years, but only 50 Rachels. And so that's how I introduce those concepts. Well, if you're really on a roll with your registrar and you think you could extend them a little bit further, there's one last concept you could introduce, and that's this concept of them understanding the difference between these expressions: relative risk, risk ratio, risk reduction, which are all the same thing. That's expressed as RR, and this relative risk reduction, which we've just talked about. And this confuses people. But essentially, what I tell people is that, look, essentially they're just expressions of the probability of that they're just all the same in a sense. They're all trying to express the probability of an outcome in the exposed or the people on treatment relative to those that are not on the treatment or not getting exposed. And that it just happens that for relative risk reduction, we express it as 25% less events. Whereas if you take the statin compared to those that are not, whereas for the RR, which is whatever you want to call it, risk reduction, risk ratio,
relative risk, they're all the same, that this term is expressing the same thing, except it's saying that if you take the medication, you have 75% of the chance of having the event compared to those that weren't taking the medicine or not being exposed. So if you think of it, it's saying the same thing, it's just expressing it in a slightly different way, and mathematically it's, relative risk is 1 minus the relative risk ratio. My preference is to express things as relative risk ratio, but the problem is if you look at a study, they might use RR, so it's good to know what those terms are. I then finished off the session by talking about external validity, which is the last part of looking at a paper. And essentially it's about how will these results help me look after my patients. And the essence of this is essentially that you've discovered some new information, some results from this study, which is studying a very specific population versus and with specific interventions and comparators and measuring certain outcomes, and you've got to work out how can I bring that information from within the paper to outside of the paper onto the patient or patients that you are thinking about, and that essentially this brings you back to the evidence-based triad. You are now going back to looking at the patient's values and your clinical expertise, your knowledge of that patient in terms of who the population is, the interventions you were thinking of, the comparators, what outcomes are important to them, what harms are meaningful to them, what benefits are meaningful to them, what's important to them, and actually trying to decide how this evidence will be useful for your patient. And that's external validity. And so anyway, I hope you find that useful, and we'll stop there.